All right, good afternoon, everyone. Thank you for joining us today for our Hypertension Management Optimizing Your Electronic Health Record EHR to Improve Quality webinar. My name is Sharinda Williams Simmons. I am the Communications Lead for the National Center for Primary Care. So without further ado, I would like to turn over this presentation to Hybrid Solutions.
Good afternoon, everyone, and thanks again for joining us. Thank you, Sharinda, for the intro. My name is Phoebe Nelms. I am Program Manager here at the National Center for Primary Care, and presenting with me today will be Selena Williams, who is also Program Manager. You're very familiar with our work through Hybrid Solutions. We're located at the National Center for Primary Care on Morehouse School of Medicine's campus, and it is our privilege to be of service to you and provide information on this topic today. So please feel free as we go through to enter your questions into the chat box or to that you'd like us to address directly or refer to a clinical person for additional deeper insights into this topic. So our objectives for today, we're going to define exactly what is a patient registry and how does it serve as a foundation for population management. We know that this is a very important tool that's incorporated into most EHRs. And so how can we optimize this tool so that we can not only address patient needs, because ultimately this is what it's all about, but also address some of those quality measures for those who are required to participate in the quality payment program, and also the improvement activities that may be impacted by this particular topic. And finally, we'll just review very briefly some best practices for patient self-management. So you might wonder, registry, I know what a registry is. That's a no-brainer. However, when I was looking up research for this topic, it dawned on me that in healthcare, we use the word registry to mean so many different things. Same basic premise, but applied in slightly different ways, kind of like other things in English. If you, your right hand, a rite of passage, Mr. Right, write a letter, same sounding word, but means different things depending on the context. So we want to provide a very clear definition of what we mean when we are using the term registry in this presentation. So in this presentation, it's a system that a practice uses to identify and track specific patient populations, either through their demographics, through diagnostic codes, through their particular diagnosis. Those who are high risk have a specific list of challenges. So it's really to manage care of a specific population at the practice level, because some registries people sign up for if they have a specific condition and it's to support the research and work about that around that particular disease. And then there are the qualified clinical data registries that are CMS approved to collect and submit quality data on behalf of clinicians that may be, associated with a particular specialty. So we just wanted to be sure that we defined this term, and it's utilizing your electronic health record or some other tracking system that works best for identifying and tracking and producing reports on specific patient populations. So some refer to this as a point of care registry. And what are the benefits of having a point of care registry where you're able to identify your patient populations by diagnosis? It can really, really help with pre-visit planning so that specific tests or other needs that the patient has can be identified based on this report. And you're able to analyze data across groups of patients and see trends that you may not be able to identify or recognize gaps in if you're just looking at the data for one patient at a time. And so many patients with chronic conditions really benefit from proactive scheduling of preventive screenings and reminders and education around their particular diagnosis to help them manage their care more effectively. So you can use also the data that's generated by these point of care registries being created if you're participating in the quality payment program or other ECQMs are reported to other programs, then you can use this data to address those reporting requirements as well. How do you create this registry, maintain this registry? What are some of the things to consider when utilizing a registry? So we know patients come and go from practices, so you have to determine if your registry has a reliable patient list. That way it is targeting patients who actually are still enlisted in your coming to your practice and are still. Also, you want to be able to assign a billing or a clinical team to identify that, particularly for this project, hypertension patients, and make sure that they are entered into the registry for this diagnosis. You want to make sure that the EHR automatically updates data every time a patient arrives for a visit, and that clinical work is done. That way, the information that's generated by reports is up to date. Some practices find that it is helpful to actually utilize one specific job role to set up and manage the registry, to do the follow-up and proactive outreach that is associated with really utilizing the registry. Okay, other benefits, it allows provider feedback to update registry and ensure that the registry is correct. So we want to involve clinical staff in what are the criteria they would like to capture for the patients with hypertension in this case. Provide regular list to the providers, the team, the office, the staff to update and reach out to those patients who may have gaps in care or not reaching specific goals that they themselves have identified that they would like to reach, and encourage them to come in for an appointment. And it also is useful in setting standards for how the lists will be used in the office to identify all the ways that it can support a coordination of care for the patients. So how do we actually identify or use a registry to pull information on a particular population of patients, pull it all together? Well, one of the ways we do this is by utilizing ICD-10 codes. They're a great place to start. Fortunately for us, Selena Williams is a certified coder, and she will help us to see how all of this works together. So Selena, help us out.
Good afternoon, everyone, and thank you for joining this webinar. So as Phoebe mentioned, there's different ways you can identify these patients with hypertension. Here are a few codes, ICD-10 codes, to identify some of the patients. So the first code is R03.0. This code reads elevated blood pressure reading without a diagnosis of hypertension. So when the provider comes in, the patient may have an elevated reading, but not necessarily has been diagnosed with hypertension. So this is a good way to pull these patients through a registry and identify these patients. The other diagnosis is the primary code that most providers use, I-10, to diagnose most patients that have hypertension or are being seen and providing ongoing treatment. I-1119, this is a hypertensive heart disease without heart failure. So most of these codes will probably be used in a cardiology setting, probably also in a primary care. I-12.9 is a hypertensive with renal disease, unspecified renal disease. So these, of course, will be used in hypertension and nephrology offices. These are some of the codes they will use, along with the other one, I-12.0. Hypertensive chronic kidney disease or end-stage renal disease. And then, of course, I-16.9, hypertensive crisis, unspecified. So this is an unspecified code. And these just are a few codes that I use to kind of identify some of the codes to be used for hypertension. We know there are a gazillion codes, and of course in the ICD-10 book that you can use to pull these patients and identify these patients. So why is coding so important? It's vital that the patient's problem list is accurately reflected by the proper codes. This will give you more complete data when you use your EHR to pull reports. So for example, our R03.0 is a billable ICD-10 code used to specify diagnosis of elevated blood pressure. It's a billable code. So I-10 also included high blood pressure, but does not include elevated blood pressure without a diagnosis of hypertension. So why is this important? When we use this code, we can identify patients who may have elevated blood pressure readings, but who have not been diagnosed with hypertension. So this report can focus on those patients to provide education and resources that may help them prevent them from actually being diagnosed with hypertension later on down the line. So this works. Hypertension, of course, we know it's hereditary. Some people get it because of diet and exercise. We have hypertension in our family, but some people that change their lifestyle just because it's hereditary doesn't necessarily mean that they will put on blood pressure medication because they followed the right protocols to make their lifestyle better and made lifestyle adjustments, so they don't have to take medication for high blood pressure. So the goal of this project, of course, is to identify populations of patients to see those opportunities to make difference. We can use the EHR chronic care reports to help with that. So this next slide is a slide of a chronic care report, and as you see, this report was generated in eClinical. eClinical is one of the proper EHRs that a lot of providers use. So this practice used this delegated this report to be pulled by location, delegated it to the staff to obtain these chronic care reports. They would periodically make sure they were updated and will pull demographic information. By location, you can see it was pulled by location, it was pulled by provider or by condition. This particular practice has several facilities, so they went in and pulled this report by the different facilities. So check with your EHR vendor to see if these reports can be enabled and have them to walk you through how to make it work for you. Of course, the data that shows up in your report has to be discrete and captured in the template. So it's just very important that I'm sure that you have your EHR system can do this. It's just a point of reaching out to your EHR vendor, getting them to walk you through on how to generate these reports. So the next one is talking about templates also. Make sure your templates that are used are capturing data accurately. If they're not, fix them. Again, reach out to your EHR vendor, have them to go through the process, ensure all your staff and provider have training on the process for using the templates and satisfying alerts. Key standardizing processes. If all teams use the same template, systems of consistent care develop in the office. So that's why it's so important to train your staff to be able to pull these reports so everything is consistent across the board, being able to identify these patients and satisfying these alerts. This allows the team to develop a consistent system of care in the office. So it's just very important that all the staff is on board with being consistent, and training and process will help to implement this process. So here's another template right here I thought this had good information. This is a great template that is used to capture actionable data and holds the patient accountable for their care. So you see this template when the patient comes in and asks, did you take your blood pressure medication today? It says taking blood pressure medication as prescribed. Are they taking it as prescribed? Are you having any other problems with your blood pressure medication? And so these are alerts and templates that are put in place to identify any issues or problems the patients are having with hypertension management. Clinical decision support tools. Clinical decision support tools are also a great tool to remind the team if a patient is missing care. Turn on a few meaningful alerts and pay close attention to fulfilling these alerts. This is a requirement for the Medicaid promoting interoperability. If any providers on the line are participating in that, this is one of the requirements. You have to select clinical decision support tools. And of course, it sets reminders, alerts, and your flow sheet to refer patients to evidence-based care, and then use these alerts to remind the team of any missing care. So of course we know alerts that pop up, sometimes it can be an overload of alerts. So we want to make sure we're pulling the right data and setting the appropriate alerts in the systems, in the EHR system. And this is something that sure is not a cost to you. It's probably already in your EHR. It just has not been enabled. So here's another clinical decision support tool, and this talk about order sets, and this is another, of course, requirement. It goes along with the clinical decision support tools. So it says common medications preferred by your practice, generic, so you can set up clinical decision supports and order sets within your system to identify the medications that the patients are using. You can set it up by the labs that are being done, any kind of labs that are being drawn based on whatever they're being seen for pertaining to the hypertension. You can set order sets for that in your EHR system. Home monitoring blood pressure prescriptions, that is also a order set that can be set up in your system. And then education materials or referrals to dietary and educators is also a good order set that can be set up in the system to keep educate the patient on their process of monitoring their blood pressure at home. So for example, here's another clinical decision support tool. So for example, you see this patient's blood pressure is elevated. So this is an alert that it's in red, it's in bold. It states that this patient's blood pressure is elevated. So it prompts the provider to make a clinical decision support. So this is just an example. And like I said, a lot of this can be set up in your EHR EHR system. So here's another provider that I work with, and I just thought this was really cool how she has some of the alerts set up in their system for clinical quality measures. We know that's also required for the Medicaid Promoted Interoperability Program and also the QPP program, the macro program. So this is an alert that they have set up in their system to identify the patient's blood pressure, if it's high or if it's normal. And on the side here, you see that other clinical decision support rules. This patient has has chronic kidney disease. So this is another alert that's set up in the system for this patient. So this is a good way to optimize your EHR. So we should be taking advantage of this, all this stuff that is in the system to help us manage and identify these patients. Take advantage of these alerts and the tools that are in your EHR system. I'm going to turn it over to Phoebe, and she's going to go into talking about some of the clinical quality measures for hypertension.
Okay, would be helpful if I unmuted myself. Thank you very much, Selena. We have quality measures that are a part of the QPP program. Some of these can be reported using your EHR, and of course, they would have to be measures that are available to you that are tracked through your EHR, and they would be electronic clinical quality measures. They're available in detail, the specification sheets for each of these measures on the qpp.cms.gov website. We just want to review the highlight of these quality measures. So the registry of patients, how this can relate to your quality payment program reporting. If you create a registry of patients with hypertension, it can be used to focus on this diagnosis and address quality measures for clinicians that are eligible to participate not only in the QPP, but also in the Medicaid EHR incentive program. One of those is the quality ID number 236, controlling high blood pressure. It is a high priority MIPS clinical quality measure. And we'll go a little further into the description of this measure a little further on the next slide probably. And also quality ID number 317, preventive care and screening for high blood pressure and follow-up documented. So for quality ID number 236, the description reads, excuse me, percentage of patients 18 to 85 years of age who had a diagnosis of hypertension overlapping the measurement period and whose most recent blood pressure was adequately controlled during the measurement period. So it provides the guidance of which patients would fall into the numerator, qualify to be included in your numerator, and also patients that would be qualified to be included in the denominator. Of course, that's how it's related to coding, because each measure specification sheet also includes an extensive list of codes that matches the different scenarios that might present. So there are also codes to indicate who is not included in the denominator exclusions. For example, someone with end-stage renal disease or in hospice care, and so on. So the measure specification sheets are very detailed and very valuable guides to guide how you code for this in your billing system, and then have that match up with your clinical system. So we're going to move on to the next one, the instructions. It's to be submitted a minimum of once per performance period, and that performance period is 12 months for this particular measure. It's for patients with hypertension seen during that 12-month period, and only blood pressure readings performed by a clinician or remote monitoring device are acceptable for a numerator. If no blood pressure recorded during the performance period, then the patient's blood pressure is assumed not controlled. So again, the measure specification sheets, we have some resources that we've put into the chat box where you can access the detailed measure specification sheets through the Quality Payment Program resource library. And we encourage anyone who would like to address these measures to really get familiar with the specification sheets in detail, because there's so much valuable information contained in each one. Okay, so then we have the next quality measure, ID 317 for preventive care. Percentage of patients age 18 and older seen during the reporting period who were screened for high blood pressure, and a recommended follow-up plan is documented based on the current blood pressure reading of pre-hypertensive or hypertensive. So that's where that code that Selena talked about comes in, the R03, is it, Selena? That you can identify those patients who may be tracking with elevated blood pressure readings but have not yet been diagnosed as hypertensive, so that you can provide that lifestyle counseling that she was talking about. And we also want to make sure that the numerator criteria are met, that not only is the patient screened, but also that you document the follow-up plan. So this is just an overview of the instructions. Again, check this measure specification sheet for more details. This would be performed once per performance period by an eligible clinician. And so the patient cannot self-report. This has to be a measurement obtained by the clinician, and it must include the systolic and diastolic blood pressure measurements, and a documented follow-up plan must be related to current blood pressure reading. The patient referred to primary care provider for blood pressure management. And also there are, again, denominator exclusions for this particular measure, and you would want to be sure to check that to document it, have it reflected in your coding and your system. Now we'll talk about an improvement activity that also is related to hypertension. It's improvement activity IAPM 13, chronic care and preventive care management for empaneled patients. So the resource library has a very important document that lists the validation requirements, how do you actually show that this took place, that you're doing this activity, this improvement activity? How do you document it? That's one of the, so for our quality, we can use the codes that are prescribed in the measure specification sheet. But for improvement activities, this is the area where there's so much more flexibility, and so that sometimes leads to uncertainty as to how do you show that you're actually doing this? How do you document it? And what does this particular improvement activity require? It requires that the practice creates an individualized care plan for chronic conditions. Use evidence-based condition-specific pathways for care. Many of these guidelines are available through the Million Hearts project. That's a very good resource to use. Also, use pre-visit planning to optimize preventive care and team management of chronic conditions. So again, that's where that registry comes in, being able to plan the visit and optimize ways that you can get ahead of how patients can be identified if they're headed towards maybe a diagnosis, but then can be supported through education and lifestyle management to avert that. Use panel support tools to identify the services that may be due. Use reminders and outreach to remind of services due, and also to conduct medication reconciliation. So again, the details about this activities requirements can be found in the resource that's on the resource library. And when we go to the next slide, we'll see how we can document some of this. When the practice decides on an improvement activity, they may do so during a team meeting or a planning session. So the notes, the appointments from that planning session can serve as a part of your documentation at the beginning of the process. And then you can also use this example of a worksheet for testing change. Many people know it as a PDSA, Plan, Do, Study, Act document. So you can describe your plan, which is to meet, of course, the activity description for this improvement activity. That is allowing the patient the opportunity to develop and adjust an individualized plan of care as appropriate to their age and health status, including their health risk appraisal, their gender, age, condition-specific care services, and a plan of for addressing their chronic conditions. And again, using evidence-based specific pathways for care of chronic conditions, which might include, but may not be limited to, the NCQA Diabetes Recognition Program and the NCQA Heart Stroke Recognition Program, using pre-visit planning, that is preparation for conversations or actions to propose with the patient before an in-office visit to optimize preventive care, and team management of patients with chronic conditions. Use panel support tools and other technology that can use clinical data to identify trends or data points in patient records to identify services due. So that might be the plan. That's what you're trying to accomplish. Assign someone to be responsible, a target date, and where it should be done. And then list the things that will be needed to support this process, who's responsible, and so on. And then make a prediction. Well, if we implement this process for our patients, what do we want to see happen as the result? And then you also document the results that you have. And this document can serve as part of your evidence. And of course, any reports around pre-visit planning or documentation would also be able to support your evidence if you are ever randomly selected for an audit. The audits that we did hear about in the quality payment program were centered around improvement activities. Not this particular one, but we want everyone to be prepared and document the processes and keep that documentation We say 6 years, but it's 6 years and 3 months. So let's say 7 years. And we want you to keep that documentation for 7 years. All right, this is more of the same. We really talked about this in detail in the previous slide. Okay, so what's the point of this slide? Well, this is a $3 million Stradivari. It is an amazing instrument. And there are very few of them in the world. However, if I were going to try to play this, it would sound horrible. But somebody who has training and practice can make beautiful music with this instrument. So likewise, with our electronic health records, the technology that they house, it's an amazing tool. And of course, some EHRs are more user-friendly than others, but we want to optimize the ones that we have in use and really try to develop skill at using them to generate the kind of information that will really support our reporting for quality programs and incentive programs, for really being proactive in managing our patients and generating the results and the data that we want to get. So it might take training and practice and consistent attention. It does require some time, but good data in should really help us get good data out to support patient care. I was watching a video this morning that many of the patients who have the hardest time recovering from the coronavirus are those with underlying health issues. One of those underlying health issues that was reported was hypertension or any cardiovascular challenges. So especially at this time, it's really great to be able to optimize our analysis tools to identify patients that we may need to support in targeted ways. So after we have identified patients for focused education or to close gaps in care, how do we actually encourage our patients to follow through? What can we do to enable self-management? Selena, I know you have a few evidence-based pointers to share with us at this time.
Thank you so much, Phoebe. Well, as Phoebe discussed, we want to kind of get the patients involved in their care and hold them accountable. It's important that they self-management for hypertension and just kind of follow some things at home when they're not with the provider. So the first one is use the visit summary to provide teach back about medications, appointments, and lifestyle goals. So for example, if the provider is in, we know sometimes they can't, you got to speak to them in their language, a way that they will understand it. So give them the feedback and ask them to repeat what you said. That way you would know that they understand it. So teach backs are good with giving back to the patients. Present the visit summary ahead of the visit and have the patient review the medications for you. So go over the medication list. This is usually done by the nurse when the patient is checked in. They go over the medication reconciliation list, have the patient to repeat it to them. Make the visit summary speak to the patient in their language at their health literacy level. Use recall functions to support patients with self-care goals. Call them, email them, or text them. Upload motivating patient education tools into the EHR for easy print. This is also a requirement with the Medicaid Promoting Interoperability Program. Providing this education resources through the portal or to the patient electronically is one of the requirements that has to be met for the patient. So some of this stuff that has to be done anyway. It's a requirement with some of the incentive programs. Use the portal to contact them or have them report home blood pressures to you. This is also a requirement, communicating with the patient through the patient portal. So this is just a few tips that we wanted to give to encourage your patients to be responsible and enable self-management. And I'm going to pass it over to Sharonda Williams for questions.
All right, awesome. So this was a really great presentation and a really great view to kind of look at how the EHR and hypertension management can help each other out. We do have a couple of questions that came in. I'm going to start in the Q&A box, and ladies, just let me know if you can answer this, and if not, we'll direct you all to how you can get the information. From Michael St. Angelo. He says, we are a general surgery medical practice, and we do take BP. However, our physicians are not PCPs. If the BP is higher than normal, they would say to the patient that they need to see their PCP. Our physicians would send a note back to the patient's PCP explaining that the patient's BP was higher than normal, and the PCP would need to further monitor his or her patient's BP. Does this count?
So I guess the question is, does this count as far as your quality payment program reporting? And so as a surgical center, we would say that you would want to focus on measure sets, measures IDs, quality IDs that are practice, but that is a question that I would love to consider with you offline as to whether if it's something that you guys do check, if you meet the criteria set forth in the measure specification, then of course it is something that you could report. You want to make sure that you meet the threshold for the volume of cases, and also that based on your reporting method that you have at least 70% of those patients for data completeness. So it's a decision that you would have to make if you meet those criteria, whether you can use this measure or not.
Thank you so much for that, Phoebe, and for clearing that up. And I did put Phoebe's email in the chat box so you all can speak offline as well.
Mm-hmm.
The next question we have is from Ralph O. Do the PDSA audit requirements apply to Medicaid?
So the PDS is mainly for you to track the process of what you're doing in your practice, and it's a good tool to use even if you're participating in the Medicaid program or the QPP. It's something that a good tool to use for your practice. It's not a requirement, but it is a good tool to use to be able to track the processes and procedures that's going on in your practice in case you are audited.
Yeah, so we usually are focused on the improvement activities when we talk about the PDSA for to track your activity that you're doing and serve as a evidence if you're ever audited. So I don't think that I know the quality payment program has that category of improvement activities, but I think the Medicaid EHR incentive program measures require electronic reporting as evidence. It has to be generated. Many of the requirements have to be met by actually creating numerator denominator ratios of the measures that are outlined. Whereas the improvement activity for the quality payment program, you don't have to report any numerator denominator. You don't have to use an electronic health record in some cases as your evidence. So that there are differences there. But I know for sure if you're doing an improvement activity for the quality payment program, you do want to have some method. And this is not, of course, the only method. This is one that many practices have found easy to use and applicable to a wide variety of improvement activities.
Okay, and we had a comment here in the Q&A box, and I just wanted to see if we can clarify if it is correct or not. It looks like they're saying to let your audience know that providers can be reimbursed by monitoring blood BP. Is that true, ladies?
Well, I don't have the exact code, so if you would get that information, if someone's asking that question, and I can research that. I know they can be reimbursed, but as far as the code, I do not have that, the
Okay.
appropriate code that they will bill for that.
So, Holmes, I'm putting Miss Selena's email here down in the chat box that you can reach out to her offline for more information. And do we have any additional questions or anything else before
So
we
I know
move?
that. I know that through CCM, chronic care management, doing it as a part of CCM may lead to higher reimbursements, because many private payers also incentivize the management of chronic conditions. So we'll do a little more research into that. That was an excellent question, and we thank you so very much for your participation, for asking us. It's really great to interact with you lovely people who attend our webinars, and we thank you for having the opportunity to do so. And we want to hear from you as far as how we can more effectively support you. We thank you so very much for your service to the community at this very challenging time in our history. And we know that you all are at the front lines, and you are our heroes. And we want to thank each and every one of you for your work in addressing the health needs of the population at this very critical time. We don't know where we'd be without each and every one of you supporting your doctors and your clinical staff doing the work that they do. So feel free to reach out to us. What we don't know in the moment, we can definitely research. We love research. And we have also a few announcements regarding our upcoming activities. Of course, we have webinars each month on the third Tuesday from 12 to 1. And we hope you can join us for future webinars. And here is the next slide is a list of our resources and contact information. So thanks again, everyone, for joining us.
Again, and I just want to say for participants that are still online, we will have this webinar available on our website at a later time in our archive. Thank you so much for joining us today, and have a great week.